First, my typical next step for us is respiratory. Again, I'm always going to at least begin out here and remind you of what the colors mean so that you can prepare yourself for the level of information that you're going to have to cover. For respiratory, there's a lot of anatomy that should be known. So you know things like upper respiratory versus lower respiratory. So you know things like choking, the connection between the nasal cavity and the oral cavity, etc. There's some basic anatomy to know, and while there's a lot of anatomy, the respiratory system has even more physiology. I like the physiology. The beauty of the respiratory system is that even though there's a lot going on, it can be simplified by simply knowing that you have to follow an oxygen molecule. When you follow that oxygen molecule, you can see that there are barriers to the oxygen getting to where it needs to go in cells. So each of those barriers represents a possible pathology. So there's a lot of pathology connections in respiratory, but again, since they're simply looking at blocking a molecule from getting to where it needs to go, you can break them down fairly simple. So respiratory is a great place to work on some of our big ideas. One of our big ideas is to take something complex and make it simple. Also, since everything needs oxygen, you can explore how one system can alter other systems. That's called organ-system interrelationships. Also, this little molecule oxygen, as well as carbon dioxide, can affect all the way up the hierarchy. And by hierarchy, we mean atoms, molecules, organelles, cells, tissues, organs, and organ systems, and then organisms. So oxygen is affecting each of those levels of hierarchy. So you want to keep an eye on that too. One last thing to keep an eye on is CO2. We're going to focus on oxygen, and most doctors and nurses are going to be more focused on oxygen, but respiratory therapists will want to be sure that there's not too much carbon dioxide because it causes blood vessels to dilate and things like that. So there's a lot to follow in this thing that you do 15 to 20 times a minute, which is to breathe. As I said a little bit, we're going to break things down into respiratory anatomy and respiratory physiology. The key thing in this chapter is that you can't really cram. You'll want to get the anatomy down early, and then you'll want to learn the physiology. Then a primary way you're going to be tested is to understand the pathologies that affect respiration. You can't really get the physiology without first knowing the anatomy. You can't really get the pathology without first knowing the physiology. So this section will punish the crammer because I don't think you can get all those parts in just a few days before the exam. You got to get the anatomy done early, then you got to work on the physiology, and then you got to wait for the pathology to click too. Just some introductory slides. What a cool picture of Everest. It just really makes me think of the value of oxygen because there's not enough oxygen on Everest. The three main functions of the respiratory system are to supply the body with oxygen, to dispose of carbon dioxide, and to provide acid-base balance. We're going to come back to acid-base balance with the urinary system. I don't know if I've mentioned it yet, but the urinary system is the most difficult system in AP2. And why acid-base balance? When you're making ATP, you're pulling hydrogen atoms off carbon-based molecules like glucose. Those hydrogen molecules are acid, so you need to get rid of them. We will talk at length when we get to the urinary system about the connection between oxygen, carbon dioxide, and acid. And I don't know if I've mentioned it before, but the urinary system is the most difficult system in AP2. What part of the cell uses oxygen? I've mentioned this before, but we're following an oxygen molecule into the body and following its long path. Where's it going? Do you remember? It's going to go to the mitochondria, some to the peroxisomes, where it oxidizes things. Most breathing disorders, such as asthma and emphysema, involve difficulties in breathing in. Sounds good. Well, maybe for asthma, but not for emphysema. Another thing to remember is that there are two-way streets here. You have to get oxygen in, but you have to get carbon dioxide out. You need to get air in, but you also need to get air out. Asthma is more of a difficulty of getting air in. Emphysema is more of a difficulty of getting air back out. Revitalizing? No, they're completely worthless. A cool thing about your body is it's pretty good at this. It's pretty good at picking up oxygen. We'll see the data later, but when hemoglobin is leaving your lungs, it's 100% full, so breathing in additional oxygen isn't going to help you fill up beyond 100%. Have you ever put a pulse ox on your finger? So a pulse ox is a little thing that shoots a laser at your hemoglobin, and it can tell if the hemoglobin is full of oxygen or not. 92% is bad. So only having your hemoglobin 92% full of oxygen is a bad thing. So you're very good at carrying oxygen. One of those perspective things again, if you look at things from the wrong angle, you are, what's going on here? So this is the wrong angle. While I typically point out a bunch of pathologies that relate to our content, I'm kind of cutting the cord this time. And for this exam, you will need to research the pathology connections yourself. About half the points on this test will be to describe how a pathological condition alters the physiology. So you'll also need to have a pathology for each step in the respiratory system. So I'll say this multiple times, but let's go through it simply. You have to get air into your lungs. Then you have to get the air into the blood. Then the blood has to carry the air. The air has to come out of the blood and get into the tissue. And once in the tissue, the cell has to be able to use the oxygen. So you'll need a pathology from each of these steps. Also, since many pathologies will affect 2 steps, if a pathology affects 2, you'll have to describe both. This is the right perspective. So you should have some aha moments in this section. Seek the understanding. Don't just try and memorize things, because you'll have those aha moments. While I've briefly outlined the expectations, please do find the official respiratory exam question description on Talon. As is typical for me, there are infographics. You might find the anatomy one useful for reviewing all the anatomy. I like being able to get everything on one page. Honestly, the physiology one may not be as helpful because we're going to draw out all the steps in physiology in class on the board. So that might be a better tool for you. If you want a different view, though, of what we do on the board, then the physiology one might be helpful. You might want to pull out the anatomy one to follow along. I do like that the physiology one is bigger because it's more important, but you can't really get the physiology unless you know the anatomy first, so that's why we'll start the anatomy. So again, maybe pull this out so that you can refer to it. One of the first key distinctions is to divide up anatomy into a conducting zone, which just gets air down into our other zone, which is the respiratory zone. The respiratory zone is where air is actually exchanged with the blood. About 150 milliliters of the air in your breath is wasted because it will only fill up the conducting zone. So someone who has shallow breaths is not getting air down into their respiratory zone. The conducting zone is built of a rigid airway. You can feel your trachea yourself or feel the airways in the cadaver. In fact, in the root of the lung where the blood vessels go in and where the airways go in, you can easily distinguish arteries and veins from the much more rigid conducting zone structure. So when you feel around at the entry into the lungs, you can tell which ones are airways because they're so much more rigid. The conducting zone includes all the airway getting air down into the lungs and includes the nose, the nasal cavity, pharynx, and trachea. Once we get into the lungs, we get bronchioles, alveolar ducts, and alveoli. Since air is actually exchanged here, this is the respiratory zone. Which of the following is not a function of the conducting zone? It doesn't do gas exchange. That would be the respiratory zone. We're going to step through the major structures of the conducting zone. So again, as redundancy, if you haven't pulled this out, maybe do it now. It's going to be so much easier to memorize the anatomy if you make this one big sheet of paper with all the necessary information work for you. So it'd be nice to be able to take the slides, to make this big sheet of paper work for you. And then once you have this big sheet of paper working for you, then this is the only piece of paper you have to study to get your respiratory anatomy down. The nose functions as an airway, so air can go through here. The nose warms and moistens the air. There's cilia and mucus that will catch debris, so air is filtered. Your nose adds some tone to your voice, which you can mimic by blocking it by speaking while your nose is plugged. Of course, the smell receptors begin at the roof of the nose and nasal cavity as well. The nasal cavity is in and behind the nose, so here's the nose, nasal cavity is in and behind. The nasal septum divides the nose, and one cool thing that you can see in this picture is that often one side is more inflamed than the other. So this side, this right side of this person, is much more inflamed, and the left side is much more open. Sorry, from a radiological technician's point of view, right and left is the view from the camera, and so this would be the person's right, this would be the person's left. So when you have a stuffed up nose, one side is usually worse than the other. The front openings of the nasal cavity are called the nares, while the posterior opening is into the nasopharynx or nasopharynx. The ethmoid bone and sphenoid bone, so sphenoid and ethmoid bone, form the roof. Do you recall the holes in the ethmoid bone? So when you look down at the ethmoid bone, there's holes in it. What do you think those holes are for? The hard palate in front and the soft palate in back form the floor of the nasal cavity. You can always tell the hard palate from the soft palate by running the tongue along the roof of your mouth, and you'll feel that the hard palate is in front and the soft palate is in back. The very tip of the nose is called the vestibule and is right above the nares. The entire nasal cavity is lined with respiratory mucosa and epithelia that releases mucus to trap debris and pathogens. At the very roof of the nasal cavity is the olfactory mucosa, where there's smell receptors. The olfactory receptors will pass through the ethmoid bone to pass smell information up to the olfactory bulbs, which are cranial nerve 1. So this is where the holes in the ethmoid bone come from, is those sensory neurons passing through the ethmoid bone up into the olfactory bulb, or cranial nerve 1. The nasal cavity doesn't want cold air getting into the lungs where it can cause constriction. Also, we don't want to lose heat through our breathing, so the nasal cavity will warm and humidify air as it enters. The nasal cavity will also try to reclaim heat on breathing out. There's cilia and mucus to trap pathogens and sweep it towards the stomach, where it will be destroyed by stomach acid. Sneezes are triggered by the irritants in the nose, as opposed to coughs, which are triggered by irritants deeper in the airways. A key to filtering, heating, and moistening the air is to have narrow airways. The narrowing is created by the nasal conchae, so you see how narrow this is. Another term for the conchae are the turbinates, because they cause turbulence in the air, which makes the air swirl, so anything floating in the air is more likely to hit the wall of the nasal cavity and get stuck in mucus. There are 3 turbinates, or conchae: the superior, medial, and inferior. Just a cool picture. Also, a sagittal section of the head. We can also look at a sagittal section of the head in the lab. Another structure that helps warm the air are the sinuses. Sinuses lighten the bones of the skull, but they also have rich capillary beds, which will bring in warm blood near the nasal cavity to warm the air as it passes through. The proximity of the sinuses to the nasal cavity also means they're prone to infection. Think about that again. So you might have an inflammation in a confined space, which can be painful. As an aside, I always like to point out to students that there's 2 types of people in the world: those that love their neti pot and those that haven't ever tried one. If you've tried a neti pot, you've come to appreciate that they're really good at washing out nasal passages. So they're sort of disturbing, but they work very well. Just be sure not to use tap water, as you can inject bacteria, and that bacteria can actually go through your ethmoid bone and cause meningitis. But if you have sinus infections a lot, it's worth trying a neti pot. Next up is the pharynx, or throat, and larynx. The pharynx is a funnel-shaped tube with skeletal muscle. We know it's skeletal because we can control it, so you can swallow when you want to. We divide the pharynx into 3 parts: the superior nasopharynx, then the oropharynx, and then the inferior laryngopharynx. The nasopharynx should just have air and the occasional milk from that one kid in elementary school. Kind of kidding. The oropharynx passes food to the esophagus and air into the larynx, and the laryngopharynx runs from the epiglottis to the larynx. Let's go into each of these with a little bit more detail. So the nasopharynx goes from the sphenoid to the inferior border of the soft palate. This should only be air in here, and it's sealed during swallowing to prevent food from entering the nasal cavity. The epithelia is pseudostratified columnar to create a relatively thick epithelial barrier. There are tubes between the airway and the inner ear to balance pressure. Those are called the eustachian tubes, or the pharyngotympanic tubes, or auditory tubes. The oropharynx runs from the soft palate to the epiglottis, shown here in green. The opening into the oral cavity is called the fauces. Both food and air will pass through the oropharynx. Because there might be abrasion, the epithelia is stratified squamous, a tissue that allows cells to be scraped off but still maintain a barrier. The palatine tonsils hang down from the soft palate, and the lingual tonsils are underneath the tongue. The laryngopharynx runs from the epiglottis down to the larynx. It's also a common pathway for air and food. When food and air get to the larynx, that's where the food will split, with the food going down the esophagus and back, and the air going into the front, where the trachea is. The larynx is also called the voice box because here's where there are folds in tissue that allow us to make sounds. The 3 functions of the larynx are to provide an airway, route air and food into the right path, and then make sounds for voice production. The epiglottis extends from the larynx and is a switching mechanism. So the epiglottis is here, or it's this flap up here. When food catches the tip of the epiglottis folds down to cover the larynx. Epi means above, so the epiglottis is above the glottis. The glottis is the vocal cords, which vibrate to produce sound when air passes over them. We can divide vocal production into things like speech, where we push air over the glottis to make sounds. The length and tension of the glottis determines the pitch of the sound, high-pitched or low tones. How much air is passed over the larynx determines loudness. And once sound is made, the pharynx resonates, amplifies, and improves sound quality. Also, the sound is shaped by the throat, the tongue, the soft palate, and the lips. For example, if you make a ga sound, that comes from your throat, or a pa sound comes from your lips. The larynx is held closed during coughing, holding your breath, and something called Valsalva's maneuver. You use Valsalva's maneuver when you need to increase pressure in the thorax or abdominal cavity. You do this when lifting something heavy, when you kind of have that or when defecating. It was pointed out to me by an EMT that you can't go number 2 unless you take a breath first. So try and breathe out all your air and then try and defecate, and you won't be able to do it. Interestingly, this pressure can also push on the heart to such an extent that blood flow to the heart is reduced. So Valsalva's maneuver can actually lead to a heart attack. So if you're bearing down, often doing Valsalva's maneuver, it will push on the heart and limit blood flow. So if you're having a problem defecating, this can actually lead to cardiac arrest or heart attack. Do you know who famously died on the toilet from too much Valsalva's maneuver? Well, that's all right, Mama. It's interesting to note that pain medications like morphine and things like that cause incredible constipation that can lead to these problems. Once air passes through the larynx, it's in the trachea. The trachea passes into the mediastinum. Remember that from AP1? Bronchial tree anatomy. So now we'll look at the bronchial tree. The last ring of cartilage right here is the carina, and it marks the beginning of the right and left bronchi. Air that's made it this far is pretty warm, filtered, and moist. Bronchi split multiple times into primary, secondary, and tertiary bronchi. From there, they become bronchioles, which are in pink, and then we'll get on the next slide to terminal bronchioles. So poor choice of color with my background, but the blue here are the terminal bronchioles. From the bronchioles, you go into the terminal bronchioles. As air moves inferiorly, the anatomy changes. This is what you'd expect, because at the superior regions, the main goal is to keep the airway open and provide a good barrier against bacteria. But as the airway moves inferiorly, the goal becomes to thin down so the air can move into the blood. The airway moves from pseudostratified columnar to transitional to simple squamous, and the cartilage breaks up so that you have less cartilage blocking the ability of air to get into the alveoli. After the terminal bronchioles, air enters something called a respiratory bronchiole, shown here, and into alveolar ducts, which would be deeper in, eventually into the alveoli, which are the air sacs. You have approximately 300 million alveoli, and that accounts for most of the lung volume. The alveoli are small, with a thin wall between the air and capillary carrying the blood. Because some of the air in the respiratory bronchiole can enter the blood, this is the beginning of the respiratory zone. So the respiratory bronchiole is the beginning of the respiratory zone. So just to be clear, terminal bronchioles are in the conducting zone, while the respiratory bronchioles are in the respiratory zone. Looking closer at the alveoli, there are 2 or 3 main types of cells. The reason I say 2 or 3 is that structurally there are 2. The type 1 cell makes up the wall of the alveoli and is pink here, all these pink cells. Type 2 cells make surfactant. So the type 2 cells are the little brown or beige ones. They make something called surfactant. A third type of cell that we could add to this but aren't really structural are the macrophages, or the white blood cells, the immune cells. Here's the same basic text but with the actual section of the lung, so you can see what the alveoli really look like rather than just an artist's rendition. Just a closer look to type 1 cells, pink, type 2 cells, beige, and then the macrophages. If you look really closely at the capillary, you'll see that there's basically just 2 cells between the air in the alveolus and the blood in the capillary. So there's the cell that makes up the alveolus, and there's the cell that makes up the border or the wall of the capillary. So there's a really thin barrier here. Now that we've talked about type 2 cells as making surfactant, let's look at what surfactant is. First, remember from the early chapter on chemistry that water molecules feel each other, in a sense, because the water molecules are tied together with hydrogen bonds. This makes water have some cool properties. Can you remember those? So it's like cushioning, has a high heat of vaporization, high heat capacity, it's a polar solvent, and it's cohesive. So the hydrogen bonds make water stick together, and if you line the alveolus with a thin layer of water, that water wants to collapse into a drop. That's why I have a picture of a droplet here. That would make the alveolus collapse as well. So the cohesiveness of water needs to be disrupted in the lungs. Otherwise, the water lining the alveolus will always try to pull in the alveolus to collapse into a ball. So notice the alveoli are smaller in the top slide of low surfactant. The most common cause of low surfactant is being born before the lungs start making surfactant, or exposure to breathing hot air, as in a house fire, can also reduce surfactant. Let's take a closer look at alveoli. Alveoli are surrounded by fine elastic fibers. They're not really shown in here, but we're pretending that there's these fine elastic fibers wrapped around these alveoli. While inhalation is an active process, so muscles contract, the diaphragm pulls down, exhalation is just the recoil of the elasticity of the rib cage and the elastic fibers around the alveoli. Losing these elastic fibers will make it hard to breathe out as an emphysema. Lung anatomy. Let's look at the gross anatomy of the lungs. We'll get the text out of the way here. I'll read through that, and then we'll look at actual lungs. The root is where the airways and blood vessels enter the lungs. The costal surface of the lung is up against the ribs, so this would be the superficial surface. The apex is the narrow tip, while the base is the bottom of the lungs. The hilus is the indentation at the root of the lung. So again, note the root, the hilus is the indentation, or the hilus is the whole area here. I guess here's where it's labeled. Note that the right lung has 3 lobes, while the left lung only has 2 lobes. The indentation in the left lung where the heart sits is called the cardiac notch, and since the heart takes up part of the left lung, that's why the left lung only has 2 lobes. Here we can see the lobes a little bit better. The lobes are pretty easy to name. Superior, middle, and inferior for the right. Superior and inferior for the left. And again, note the cardiac notch outlined here in green. What I like about this cross-section is that it shows almost everything in the thorax that's not heart and that's not spinal cord is lung. So here's heart, here's spinal cord, all of this is lung. The reason I like this is because when you have a human torso model in the lab, these little cute little lungs pop off the front, and so you think your lungs are small. But your lungs basically take up everything in the thoracic cavity other than what the heart is and what the spinal cavity is. So it takes up a lot of the space. The blood supply to the lung is kind of unique. First, there has to be 2 circulations. So you know of one circulation, that's blood that's going to the heart to be reoxygenated. But that blood has been to the entire body already, so it's not very nutrient rich. So first, there has to be 2 circulations because one has to carry fresh blood with nutrients. This is the bronchial artery. The other circulation to the lung is the one that just needs to be reoxygenated. Once both blood supplies enter the lungs, they can return together. They don't need to stay separate, returning back to the heart. So there's 2 arterial pathways to the lungs and only 1 venous pathway out. This is a review, but note that the circulation taking blood to the lungs is through the pulmonary arteries. Blood returns to the left side of the heart through the pulmonary veins. So bronchial arteries are separate from pulmonary arteries. Bronchial arteries come out of the aorta. And when the blood's ready to return to the heart, bronchial veins join with pulmonary veins, the anastomoses. An important thing to know about the heart, as it's important to the physiological function of the heart, is the coverings of the lungs called the pleura. There are 2 pleura with a space between them. The parietal pleura is the outer covering. Parietal means up against the wall, so the parietal pleura is up against the thoracic wall. The parietal pleura covers around both lungs and the heart. The visceral pleura covers each lung individually. Visceral means inside, so this is the inner of the 2 layers. Think of the visceral pleura as clinging tightly to the lung. We will talk about the space between the pleura when we get to ventilation, but for redundancy, this space is called the intrapleural space. So that's it for lung anatomy. So we're going to spend a good bit of time on physiological pathologies, but you might also explore some anatomical pathologies like flail lung. Next up, we turn to physiology. One of the first things I might mention is that though I still think there's value when making these videos to go through everything slide by slide, sometimes it's easier to turn things into a story by drawing everything out into a big picture, and that's what I've done for the respiratory system, or at least the majority of the respiratory system. So I might go watch those videos first, either on YouTube, or we'll also do it in class, and then come back to this content to fill in any holes you might have. But for doing the pathologies on the test, the drawings we put on the board or on this YouTube should probably be your focus and should be sufficient, honestly. There's a couple of slides at the very end. I might jump to the last couple of minutes where we talk about respiratory control. But other than that, all of these slide-by-slides are covered by the big drawings. Breathing is the process of drawing air into the lungs in inspiration or inhalation, or pushing air out of the lungs in expiration or exhalation. It's probably a good idea to get used to these overlapping terms now because it happens a lot in the respiratory system where you have a lot of names for the same thing. This patient is hooked up to not a respirator. A classic question because so many TV shows talk about a person being put on a respirator. If you're in a healthcare setting, you'll call this a ventilator. Respiration is the entire process of delivering oxygen to the tissues and cells. This machine only gets air into the lungs, a process called ventilation. But this machine does not do the entire process of respiration, so this is not a respirator. The 5 steps in respiration are simply put. Ventilation is to get air into and out of the lungs. External respiration is to exchange gas between the lung and blood. Transport is the moving of gas in the blood. Internal respiration is the exchange of gas between the tissue and blood. And cellular respiration concerns how cells use and produce respiratory gases like oxygen and CO2. Those steps are mapped in this infographic, but since making the infographic, I've started drawing everything on the board, so you might look at those instead. You can get your own copy of the drawings by looking in the Show More tab of the video on YouTube. Though I'm not really using this infographic, I might still use it just as an introduction in slides, because we need to talk about some basic pressures, we need to talk about Boyle's law, and we'll talk about pulmonary function tests or respiratory volumes. So these infographics still kind of introduce the major topics under each of the subtopics of ventilation, external respiration, transport, internal respiration, and cellular respiration. All right, so you can see here that we got ventilation, we got external respiration, transport, internal respiration, cellular respiration. And then again, towards the bottom here, we'll do control of respiration. So ventilation is getting air into and out of the lungs. The 3 main areas we're going to cover with ventilation are the pressures involved in moving air into and out of the lungs and keeping the lungs inflated, how Boyle's law explains pathologies in the alveolus, that's the tiny little air sacs of the lungs, and pathologies in the airway, pulmonary function tests as well. We'll first look at the pressures that you'll want to know in order to understand ventilation. The first couple of pressures are the respiratory pressures. So the first is intrapulmonary pressure, and this is the pressure within the alveoli, so represented here in green and 759, 761. The other pressure is atmospheric pressure, and this is the pressure in the air around us, so the atmospheric pressure. This pressure is typically 760 millimeters of mercury. It's important to keep in mind that air moves from high pressure to low pressure. Recall that there's a space between the parietal, that was the outer one, and visceral pleural coverings over the lung. This space is called the intrapleural cavity. The pressure within this intrapleural cavity is the intrapleural pressure. It's usually 4 millimeters of mercury below intrapulmonary pressure. So again, the slide just kind of overlays some color to make it more clear that the intrapulmonary pressure is the pressure in the actual lung, in orange here, while intrapleural pressure is the pressure in the small cavity around the lung. Also note in this figure that the intrapleural pressure, as I said, is usually 4 millimeters of mercury below the intrapulmonary pressure. This negative pressure provides some suction that will keep the lung open. The reason we need this suction is that the lung wants to collapse. There's 2 forces that pull the lung in on itself. Both of these forces have been briefly introduced before. One is the elastic fibers that are surrounding the alveoli. The other force is that water in the alveoli is cohesive. Even though surfactant reduces cohesiveness, the water in the alveoli does still want to collapse into a drop of water and pull the lung cells in with it. Recall the picture of the alveoli. Recall in your mind the picture of the alveoli without surfactant. The difference between the intrapulmonary pressure and intrapleural pressure is called the transpulmonary pressure. So the transpulmonary pressure is usually around 4 millimeters of mercury. It varies a bit, but this is close enough for us. What pressure keeps the air spaces in the lung opened? I'd call that the transpulmonary. That's the one that if it goes to 0, as we're going to see here shortly, then the lung will collapse. So if the transpulmonary pressure goes to 0, the lung will collapse. A mastery level thinking would be to look up the various causes of collapsed lung, called pneumothorax. Collapsed lung might also refer to atelectasis. I'll let you look up the difference between atelectasis and pneumothorax to chase your mastery thinking. Here's a picture of pneumothorax. Now let's look at how these pressures change to move air into and out of the lungs. The lungs are going to change intrapulmonary pressure to vary above and below atmospheric pressure. So intrapleural pressure then will follow the intrapulmonary pressure, staying about 4 millimeters of mercury below intrapulmonary pressure, again to keep that suction. So when the intrapulmonary pressure is at 759 millimeters of mercury, air will move from the atmosphere, which is 760, to the lower pressure in the lungs. The lungs will be breathing in, and the intrapleural pressure will be 755. When the intrapulmonary pressure is raised to 761 millimeters of mercury, air will move from the higher pressure in the lungs out to the atmosphere. So the lungs will be breathing out, and intrapleural pressure will be about 757 millimeters of mercury. These are fairly simple numbers. You'll kind of want to understand them rather than just memorizing the numbers. So try to understand this flow of air from high pressure to low pressure. To understand how the lung lowers intrapulmonary pressure to 759 and raises it up to 761 millimeters of mercury, we need to understand Boyle's law. Boyle's law states essentially that pressure and volume are inversely proportional. If the volume goes up, pressure decreases. If volume goes down, pressure increases. I like to break things down to really see things in a simple way. That's one of our big ideas in the class. So to do this, recall from blood pressure that pressure arises when a confined substance, in that case blood, hits the wall of the container, in that case the blood vessel. It's the molecule or whatever hitting the wall of the vessel that causes pressure. So if we decrease the size of the container, the molecules will hit the wall more often, and this will raise pressure. If, on the other hand, the size of the container increases, the molecules are less likely to hit the wall, and so pressure will reduce. So pressure and volume are inversely proportional. If you decrease the volume, you increase the pressure. If you increase the volume, you decrease the pressure. Now, rather than thinking of molecules in containers, think about air molecules inside the lungs, or more specifically inside alveoli. If we can make the alveoli smaller, the air molecules will hit the wall of the alveolus more often, and so pressure will go up. This will raise pressure in the alveolus above atmosphere, and air will move out of the lung. If we can make the alveoli larger, the air molecules will hit the wall of the alveolus less often, and so pressure will go down. This will lower pressure in the alveolus below atmosphere, and air will move into the lungs. The reason to see what's happening here at the molecular level is that's one of our big ideas, to be able to relate A&P across hierarchies, how our molecules affect our organ systems. So in this case, it could be a molecule like an elastic fiber or a mucus. Also, you'll see that if there's a problem with changing the size of the alveolus, there's going to be a problem changing pressure. So if you can't change pressure, you can't move air. In emphysema, the elastic fibers around the alveoli are destroyed. You're going to see this in lab because emphysemic lungs are very spongy. Then the alveoli can't reduce their size. And if the alveoli can't reduce their size, they can't increase pressure. And if they can't increase pressure, you can't breathe out. So in emphysema, the lungs will trap air. In fact, a patient with advanced emphysema will show signs of the trapped air, so they'll have a barrel chest. And a normal individual, we're wider than we are deep, so our lateral dimension is greater than our anterior to posterior distance. But in emphysemic patients, the lateral and anterior to posterior distance are much closer. They're about as deep as they are wide, shown in this picture. In conditions where there's fluid or mucus in the lung, there's a sticky substance in the alveolus that makes it harder for the alveolus to increase its size. So water's cohesive and mucus is just sticky. If the alveolus can't increase its size, it can't decrease pressure. If the alveolus can't decrease its pressure, you can't breathe in. So things like ARDS or flu are going to make it difficult to breathe in. Whereas again, with emphysema, it's difficult to breathe out. You can think about Boyle's law in terms of the whole thoracic cavity. When the thoracic cavity increases its volume, pressure is reduced, and we get inspiration. When the whole thoracic cavity decreases in volume, pressure is increased, and we get expiration. There are pathologies that affect Boyle's law at the alveolar level, like mucus, fluid, and emphysema. There are also pathologies that affect Boyle's law at the thoracic cavity level, like a punctured lung. Maybe check out flail lung for some mastery level thinking. This slide takes us back into that infographic that I said might not be helpful, but this slide does allow me to make a point. When you're doing your pathologies, things like mucus and fluid make it hard to change volume, and thus you can't change pressure. So it's not that mucus increases pressure in the lungs, rather mucus is sticky, so it makes it hard for the alveolus to expand. If the alveolus can't expand, it cannot increase its pressure. If you can't increase your pressure, you can't draw air in to breathe. So mucus doesn't change pressure, it makes it harder to change pressure. Same here. When it comes to emphysema, emphysema does not decrease volume. In fact, it will increase volume of the lungs. What emphysema does do is that it makes it hard to decrease volume. If you can't decrease volume, you can't increase pressure. If you can't increase pressure, you can't breathe out. So you should read this in terms of it's difficult to decrease volume, then it's difficult to increase pressure, then it's difficult to breathe out. Or on this side, if it's difficult to increase volume because there's mucus in there, then it's difficult to decrease pressure, then it's difficult to breathe in. Air moves into the lungs because gas pressure in the lungs becomes less than outside pressure as the diaphragm contracts, so C. Another law of physics that helps us break down respiratory physiology and pathology is Ohm's law. If you've heard of Ohm's law, you probably link it to electricity, but Ohm's law deals with anything that flows, whether that's water, air, or electrons. Ohm's law is fairly intuitive. Flow is dependent on what is pushing the flow divided by what is opposing the flow. In air, the push is change in pressure. There are several things that can oppose flow, but in the lungs, this is mostly a problem with the airway not letting enough airflow. The reason to think about lung pathology in terms of Ohm's law is if you have a problem with the alveolus changing pressure, air isn't pushed to move. You can have the alveolus working fine and pushing air, but there's still something opposing flow. So you can have a problem with pressure, and you can have a problem with resistance, something resisting flow. We classify problems with changing pressure as restrictive disorders. I think about that name by thinking that something is restricting the ability of the alveolus to change its size. So if you can't increase the size of the alveolus, you can't decrease pressure. You can't change the pressure. If there's a problem with the airway, this is called an obstructive disorder, as something is obstructing the airway. One thing you can already start to see is that many lung disorders will affect both the alveolus and the airway. So we're going to get mixed disorders. If you have mucus in the alveolus, you have a restrictive problem. That mucus is probably in the airway too, so you have an obstructive disorder. So when the disorder is both restrictive and obstructive, this is called a mixed disorder. Another example is emphysema, where the breakdown in elastic fibers alters the structure of the alveolus, but it also affects the structure of the small respiratory bronchial airways. So it's affecting both the airways and the alveolus. It's going to get a bit redundant here, but that's because things get kind of confusing. Problems altering pressure occur in the alveoli and are called restrictive disorders. Since the alveoli are in the respiratory zone, these can also be called respiratory zone disorders. Also, since the problem is in pressures, they can be referred to as pressure disorders. I would highly recommend that you look up restrictive disorders on Wikipedia. For one, it's going to be helpful on your pathologies that you'll do for the test. Also, it's just good to see the wide variety of restrictive disorders. Obstructive disorders might be even slightly more confusing. Resistance to flow of air to the alveoli leads to obstructive disorders. Obstructive disorders happen in the conducting zone, so these are conducting zone disorders. Also, since there's a resistance to airflow, these disorders can be called resistive or restrictive disorders. That one is particularly tricky because it sounds like restrictive, so resistive sounds like restrictive. Restrictive disorders are a problem with the alveoli. Resistance disorders are a problem with the airway. Again, look up obstructive disorders on Wikipedia to see the variety. And again, keep in mind that there's also mixed disorders. We can diagnose obstructive disorders, restrictive disorders, and mixed disorders using something called pulmonary function tests. We'll get to that shortly. As a preview, can you think of how you might differentiate a problem with pressure in the alveolus versus a problem with an obstruction of an airway? Just try and think about that for a second. I mentioned this before, but we can also call obstructive disorders airway resistance disorders. Example of pathologies would include asthma, where the bronchioles constrict, obstruction of airways due to a tumor, inflammation of bronchioles, as in bronchitis, or destruction of bronchioles and emphysema. One last name to throw in there, unfortunately, is compliance. Compliance describes how easy it is to expand the lung. While compliance seems like a good thing, it's more of a Goldilocks situation where too much is bad and too little is bad. Too much compliance and the lung will expand too easily and will not recoil to push air out. But too little compliance means the lung won't increase. It'll be stiff. So compliance is directly related to the two things we talked about earlier that makes the lungs want to collapse: the elasticity of the lungs and the thorax, and the surface tension of the water in the alveolus. Some of the things that can affect compliance are scar tissue. Find a scar on your skin and see if it's as compliant as the skin around it. Scar tissue is usually pretty stiff. The presence of mucus, which is sticky, makes tissue less compliant. If there's not as much surfactant, water's more cohesive. When water's more cohesive, it makes it harder for alveoli to expand, so compliance is decreased. Damage to the thoracic cage or even pain will reduce compliance because the muscles that expand the thorax will be inhibited when it's causing pain. This is a nice slide to summarize some of the things that cause pressure or restrictive disorders. Pathologies that make it hard to increase the volume of the alveoli are scar tissue, reduced surfactant, mucus, and fluid. Emphysema will make it hard for the alveolus to decrease its size. That's still a pressure or restrictive disorder. Resistance disorders or obstructive disorders would include things like asthma, tumor obstruction, or also emphysema due to the destruction of bronchioles. Earlier I asked the question of how do you think you can measure if there are pressure disturbances in the lungs? Based on Boyle's law, we can see difficulties in changing pressure as difficulties in changing the volume of air that's in the lungs. So next, we'll turn to pulmonary function tests. There are a lot of pulmonary function tests, but we'll focus on the major measures that can determine if there's an obstructive disorder. This table is from our lab. It's also from close to a Merck manual. You can see that we can discover if there's an obstructive disorder by looking at something called FEV1 over FVC. Sometimes this ratio will give a false negative, so there's a problem, but the test hasn't found it. So we'll also look at an FEV1 of percent predicted, and you have a predicted FEV1 based on your height and your age. TLC stands for total lung capacity. This is an easy way to see if there's a problem changing pressures in the lungs, because if a normal lung is able to hold 6 liters for men and 4.2 liters for females, any value less than that could indicate either a problem breathing in or a problem breathing out. Here's some specific values. We'll also go over them in a table. So alveolar volume is how much air is reaching the alveoli each minute. Tidal volume is the amount of air moved in one normal breath. It's about 500 milliliters, half a liter. Vital capacity is the total amount of air that you can move. So you take a deep breath in, blow it all the way out, and that's your vital capacity. Residual volume is the amount of air left in the lungs after a normal breath out or normal exhalation. So even after you breathe all your air out, there's about 1 liter of air left in the lungs. That's residual volume. Inspiratory capacity is the amount of air you can breathe in after a normal breath out. Inspiratory reserve is the amount of air you can breathe in after a normal breath in. So you take a normal breath in, see how much more you can get in. That's your inspiratory reserve. These equations may help, but I'm more of a visual person, so I just like looking at the table. In this table, there are 4 main values over here on the left. So how much air is in the lung after a normal breath in, how much air is in the lung after you try to breathe all the way in, how much air is in the lung after a normal breath out, and how much air is in the lung after you breathe all the way out. Once you have these values, all the other values are simple arithmetic. So for example, tidal volume is the difference between normal in and normal out. Inspiratory reserve is the difference between a normal breath in and an all-in breath. So the difference between these two is inspiratory reserve. I try to draw this out so that between the arrows are telling you what that particular volume is. So inspiratory capacity is the difference between all-in and a normal out. Another thing that's shown in the graph is the rate at which the air is moved. If you have a restrictive disease, so notice this green arrow, green line versus the black line, it's taking longer for this person to take a breath in. So if you have a restrictive disease, you can't get as much air in and out. If you have an obstructive disease, you might be able to move just the same amount of air, but it takes you longer. So I always like to think about obstructive as breathing through like a large straw. You can get in just as much air, but it takes a lot longer. We're going to do these in lab, and that should also clean things up a little bit for us. As a suggestion for mastery level thinking, you could also look into flow volume loops. The beauty of these loops is that they can differentiate an obstruction based on where it's happening. So where there's a change in a plateau is generally what airway is affected, so you can figure out If there's a plateau, as in this person, in the large airways, then they have an obstruction in the large airways. Whereas if this plateau is down here further, then the problem would be in the smaller airways. It's kind of a cool diagnostic. An example of why you'd want to pay attention to tidal volume: all of these patients have a pulmonary ventilation of 6 liters per minute. Where they vary is in the frequency of breathing. The tidal volume of patient 5 is only 150 milliliters, which means they're only moving air into and out of the conducting zone. They're not getting any air into the alveolus. That's why the alveolar ventilation is 0 milliliters per minute. Which respiratory measurement is normally the greatest? Tidal volume would be the smallest, vital capacity would be the biggest, and if total lung capacity was in there, that would be larger still. Here's a good source for more on pulmonary function tests. If you have asthma, smoke, or a firefighter, or interested in pulmonary, you might want to do some mastery level thinking here. That's ventilation. Now we move into external respiration. External respiration includes the factors that affect exchanging the air in the alveolus with blood in the vessels lining the alveolus. There's 3 specific areas we need to look at: what factors affect gases and how they go into solution, how does the body match airflow, called ventilation, with blood flow, called perfusion, and then are there other factors that might prevent air in the alveolus from making it into the blood? So if there's fluid in the alveolus or mucus in the alveolus, that's an additional barrier between oxygen in the alveolus making it to the capillary. We can speak a little more technically about these 3 factors. We care about partial pressure gradients and gas solubilities, matching of alveolar ventilation and pulmonary blood perfusion, and then structural characteristics of the respiratory membrane. This figure is nice at hitting the point that external respiration is exchanging gases in the lung or the alveolus with gases in the blood. Specifically, we need to get oxygen from the alveolus into the blood. We need to get carbon dioxide out of the blood and into the alveolus. There's a little more detail here than can be seen. While most respiratory gases are transported in the red blood cell, about 7% of CO2 is transported in the plasma, and about 2% of oxygen is transported in the plasma. We'll come back to that when we get to hemoglobin. Back to the physics, Dalton's law states that the total gas pressure is the sum of the individual gas pressures. So gas pressures just kind of add together. When we talk about atmospheric pressure having a concentration of 760 millimeters of mercury, that concentration comes from nitrogen, oxygen, water, and carbon dioxide. I don't know that you need to have these memorized perfectly, but most of the air around us, 597 millimeters of mercury, is nitrogen. Next is oxygen at 159 millimeters of mercury. We drop off quite a bit there to 3.6 millimeters of mercury for water and 0.3 millimeters of mercury for carbon dioxide. I should say one way we might think about this is that temperature and concentration can change how much gas is in the atmosphere, or how much gas is contributing to the atmospheric pressure. Those of us with difficulties breathing, we like cool, dry air. If you warm air and it's humid, there's more water in the air, which means there's less oxygen. So it's harder to go for a run in hot, humid air. Some of you are scratching your head now and saying, but it's really hard for me to run in the cold. That's a bit different, and that's because the cold can constrict bronchioles. But in the air that's reaching the alveolus, there is going to be more oxygen in cold, dry air because there's no water to push the oxygen out. When you see that nitrogen is responsible for 597 millimeters of mercury of the 760 millimeters of mercury in the air, that might lead to the question of why isn't there more nitrogen in our blood? To answer that question, we need to turn to Henry's law. Henry's law explains that different gases have different abilities to go into solution. So if you pretend you have a glass of water, nitrogen is in the highest concentration in the air above that glass of water. That's why nitrogen is drawn the largest here. There's less oxygen and less carbon dioxide. But nitrogen doesn't like to go into solution. That's why I've drawn a small arrow here. Next is oxygen, and carbon dioxide does like to go into solution. So the concentration in the fluid or the glass and water flips, and carbon dioxide is the gas in the highest concentration in the glass of water. Oxygen is next, and nitrogen is the least. That's why when you leave a glass of water on your nightstand overnight, it will have bubbles, and those bubbles are going to be carbon dioxide. Same holds true if we replace water with blood. About 7% of CO2 in your blood is dissolved in the plasma, and like I said earlier, about 2% of your oxygen is dissolved in the plasma. One reason to pay attention to this is because we're going to equate carbon dioxide to acid. So the more carbon dioxide in the blood, the more acidic the blood. Next, we're going to turn to ventilation and perfusion. I like these sorts of slides because it keeps things listed in our heads of the 3 things affecting external respiration. So we just did partial pressures. Now we're doing ventilation and perfusion. Ventilation is defined as gas reaching the alveolus. Perfusion is blood reaching the alveolus. As you might imagine, they need to match well, as there's no point in having air in the alveolus if there isn't blood to pick it up. Also, there's no point in having blood in an alveolus if there's no gas in the alveolus. The surface area of the lung is thought to be about the size of a normal classroom. You only have about 150 milliliters of blood going through the lungs because you only have 5 to 6 liters of blood total, so you really need to spread that blood out through the lung. Another reason to match perfusion and ventilation is that when blood enters the lung, it tends to fall to the bottom of the lung by gravity. Air tends to be restricted because it's hard to get air down deep into the lung. It tends to be near the top third of the lung because that's where the air first enters. But to match these two, blood needs to be forced into the top of the lung, and air needs to be allowed to penetrate deeper into the lung. Here's a more visual representation. Notice that the top alveolus doesn't have much air in it. The alveolus is drawn shrunken, at least compared to this one. We don't really want blood going through this area as there isn't gas to exchange, so blood vessels will constrict. Constricting will also slow flow, so that even though there's not as much gas to exchange, the blood will flow slower through this region to enhance exchange. On the bottom, there's plenty of air in the alveolus. We want blood to go here, so the blood vessels will dilate. So keep in mind the elegance of the blood vessels in the lung, doing the opposite of all other blood vessels. In the biceps, if there's low oxygen, the vessel should dilate to bring in nutrients. But in the lung, you wouldn't want to dilate in a low oxygen situation, as the blood would just exit faster without having a chance to pick up oxygen. One more time then. Low oxygen, blood vessels constrict. High oxygen, blood vessels dilate. Also keep in mind, and we brought this up with the heart, if there's a problem with the lungs, blood vessels in the lungs will constrict. This is going to increase pulmonary blood pressure, leading to pulmonary hypertension. This will put more pressure on the right side of the heart, so chronic bronchitis or untreated asthma might lead to hypertrophy and then failure on the right side of the heart. That's one of those that just is going to keep on coming up in this class. Problems with the lung lead to problems with the right side of the heart. Our last part of external respiration is to see if there are any other barriers between gas in the alveolus and blood in the capillary. The respiratory membrane is really thin, so anything that makes it thicker will be a barrier between the oxygen in the alveolus and the capillary. So one cause is for there to be extra fluid or mucus. Also scarring, as in the case of smoking, can affect this barrier. One last factor is that the barrier can be destroyed in emphysema, so that the small alveoli pop into large alveoli. So at the top there, you see the alveoli getting larger in the alveolus. So normal alveolus, emphysemic. A big alveolus is not good because the air in the middle is a longer away from the capillaries. So the technical way of saying this is that there's a loss of surface area where capillaries and gas in the alveolus can come together. Also, if there's fluid or mucus in the alveolus, as in this picture down here, so all these are little additional white blood cells, and then the pink is more of mucus. Well, you've finally gotten oxygen down into this alveolus, but now it's got to go through these other white blood cells and this other mucus to get to the capillary. So think back and realize that mucus makes it hard for the alveolus to expand and get air into the lungs. Then, even when you do get some air into the lungs, the mucus may also impair external respiration. This is why I note that many respiratory pathologies will affect 2 steps. So mucus will affect ventilation and external respiration. The same is true for things like emphysema, fluid, and scar tissue. Which of the following would not directly decrease the alveolar surface involved in gas exchange? Tumors might take out parts of the lung, so that would affect alveolar exchange. Inflammatory products would bring in fluid. Emphysema would cut down on gas exchange area because the alveoli get bigger. Smoking is the answer here. It doesn't really affect alveolar surface gas exchange. Broaden out again, look at what our next step is. So we've done ventilation, external respiration. Now we're going to do transport. Next up is transport. Here we'll talk about the things that help hemoglobin to know when to drop off oxygen, and we'll talk about how hemoglobin usually doesn't drop off much oxygen. This creates a pretty good buffer, so all hemoglobin leaves the lungs 100% full, In fact, in a normal lung, it's full when it's gone a third of the way through the lung. So it's not even halfway through the lung and it's already full. When hemoglobin returns to the lung, it's still at least 75% full on the molecular level, meaning it's holding 3 of its 4 possible oxygens. And of the total pool of hemoglobin, it's about 90 to 92%, 95% full. Most oxygen is carried in the blood on hemoglobin. I've done a little rounding here when I mentioned this before. 98% of your oxygen, really 98.5, is on hemoglobin, and I've said 2, but about 1.5% of your oxygen is dissolved in the plasma. Also recall from our talk about hemoglobin when we covered blood that there's 4 hemoglobin proteins, 2 alpha and 2 beta. In the middle of each hemoglobin protein is a heme. In the middle of that heme is an iron molecule. Since the iron holds the oxygen, hemoglobin can carry 4 oxygens. Should have deleted that one, sorry. When hemoglobin is full of oxygen, 4 oxygen molecules, it's called saturated. When there's 1 to 3 oxygens, it's called partially saturated. When there's no oxygen, it's called deoxygenated hemoglobin. When there's carbon dioxide bound to the hemoglobin, it's called carbaminohemoglobin. When we take those 5 possible saturations over here and line them up on the y-axis, we see a graph like this. At the bottom is deoxygenated, and at the top is saturated. 2 of the main partial pressures of oxygen are in the lungs, where O2 is about 100 millimeters of mercury, and in the tissue at the end of the path of delivery, the partial pressure of oxygen is 40 millimeters of mercury. Note that at 40 millimeters of mercury, if we follow up 40 millimeters of mercury, we expect hemoglobin to have 3 oxygens bound. This is why we say that hemoglobin usually leaves the lungs with 4 oxygens and returns with 3. So what this does is it creates a great buffer, and it's why when performing CPR, you might think of it this way. If you're unwilling to perform mouth-to-mouth breaths, you should still do the compressions to keep the hemoglobin circulating. So again, the key thing here is in the lungs, we follow up, 4 oxygens bound. When we go out to the tissue, our partial pressure drops, but we still should expect 3 oxygens bound to our hemoglobin. A little bit repetitive here. The other thing to note then is at a partial pressure of 100, we expect 4 oxygen molecules to be bound to hemoglobin. So in short, it's full leaving the lungs. So taking additional oxygen, which we mentioned at the beginning, is not going to help a normal person. Obviously, any lung pathologies may warrant using external oxygen or maybe extreme athletic exertion. But otherwise, external oxygen is not going to help you deliver more oxygen. So it's not going to make you super duper smart or make you do better on tests or anything like that. Your lungs are already at 100%. In fact, they're far better than 100% for the most part in the sense that you've loaded the oxygen a third of the way into the lung. The arrangement of dropping off only 1 oxygen means that local tissue can get more oxygen off of hemoglobin if necessary. So without making the respiratory rate or cardiac output change, if tissue is being used, it can pull more oxygen off the hemoglobin if it needs to. So there's many things that will affect hemoglobin's affinity for oxygen, and what that means is that's how the tissue is going to pull additional oxygen off the hemoglobin. So in essence, we want hemoglobin to have a lower affinity for oxygen when tissue is doing work. This means hemoglobin will like oxygen less, and it'll drop off the oxygen to nourish the tissue. I like to represent this as a cycle where work creates situations where hemoglobin likes oxygen less, oxygen is dropped off, and the tissue is nourished. So when tissue does work, it's burning ATP. And we kind of literally mean burning in the sense that heat is generated. There may be friction too if we're talking about muscle. So an increase in temperature makes hemoglobin like oxygen less. So when you're working the biceps, there's more heat in your biceps. So as the hemoglobin passes through, it's more likely to drop off oxygen. BPG is also called DPG because B stands for bi and D stands for di. I don't think you need to know the name phosphoglyceric acid. Certainly don't need to know bi-phosphoglyceric acid or di-phosphoglyceric acid. Just know that this is a breakdown product of metabolism. So if tissue is using ATP, there's going to be more BPG around, and this will make hemoglobin like oxygen less. In metabolism, acid molecules are released and carbon dioxide is produced. Both of these are going to make hemoglobin like oxygen less. We're going to drop off the oxygen and nourish the tissue. This last one more specifically is called the Haldane effect. So carbon dioxide directly competes for hemoglobin. When oxygen's higher, as in the lungs, it kicks carbon dioxide off. When carbon dioxide is higher in the tissue, it kicks oxygen off, which is kind of perfect. I like having everything on that one figure as it just kind of summarizes everything, but the next few slides will get a bit more specific. So BPG is produced when metabolism is happening. If there's more BPG, it's going to alter hemoglobin shape to increase oxygen release. We don't necessarily need to be able to read this graph. Just know that as temperature goes up, hemoglobin likes oxygen less. It takes a higher concentration of oxygen to get oxygen onto the hemoglobin. So if you want to be able to read this graph, simply note that in cooler temperatures, the blue line here, hemoglobin is able to get to 100% saturation at a much lower concentration of 20 millimeters of mercury. Whereas at normal body temperature, there needs to be a lot more oxygen, so 60 millimeters of oxygen at normal body temperature to get a hemoglobin fully loaded. So what that means is the higher the temperature, the less hemoglobin likes oxygen. When we get to the urinary system, we're going to think about CO2 as causing an increase in acid. I don't know if I mentioned this before, but the urinary system is the most difficult system in AP2. There's going to be an equation. We're going to touch on it here shortly, but we're going to come back to it in the urinary system. And what that does is essentially, if carbon dioxide levels go up, there's going to be more acid in the blood. And as acid makes hemoglobin like oxygen less, it's going to drop off the oxygen. Lastly, the Haldane effect describes how carbon dioxide and oxygen compete for hemoglobin. Whichever is higher will better load and will kick the other one off. So since carbon dioxide is higher in the tissue, it gets oxygen kicked off to nourish the tissue, and carbon dioxide will load to go back to the lungs. When hemoglobin gets back to the lungs, oxygen now is in higher concentration, so oxygen will load on hemoglobin and carbon dioxide will be kicked off and exhaled. Hemoglobin has a tendency to release oxygen where? When pH is more acidic. So here's good multiple choice test taking skills. Is you know it has to be A or B because they're opposing. Hemoglobin has a tendency to release oxygen when acid is released, so when pH is more acidic. It would be when temperature is higher. It would be when partial pressures of carbon dioxide are higher. It would be when partial pressures of oxygen are lower. Because carbon dioxide and oxygen compete for hemoglobin, a lot of carbon dioxide has to be converted to a different form to prevent it from continually kicking oxygen off the hemoglobin. If we allowed that to happen, we would over-deliver oxygen, which might actually cause some damage in free radicals. So oxygen causes free radical buildup and can be toxic to tissues. As we said before, about 7% of hemoglobin is transported in plasma. 23% binds to hemoglobin, but the other 70% is converted to something called carbonic acid. When carbonic acid gets back to the lungs, it converts back to carbon dioxide and is exhaled. So carbonic acid is going to come up later when we get to the urinary system. I don't know if I mentioned this, but the urinary system is the most difficult system in AP2. Most of the carbon dioxide transported by the blood is converted to bicarbonate ions, carbonic acid, and transported in plasma. So that would be C. We'll see this equation. So here's the equation when we get to the urinary system. For right now, just see that carbon dioxide will join with water to become carbonic acid. Carbonic acid is how most carbon dioxide is transported in the blood. To review then, most oxygen is transported on hemoglobin. Carbon dioxide is carried back to the lung dissolved in the plasma on hemoglobin or as carbonic acid. All right, that's transport. You can already start to see things are going to get a little bit easier here. Next up for us is internal respiration. This is a bit like external respiration. Do note that internal respiration is the exchange of gases between capillaries and tissues. Some students get confused and associate internal respiration with breathing in and external respiration with breathing out, but external respiration is from the lungs to the capillary. Internal respiration is from the capillary to the tissue. The only main thing here is that gas flows down its concentration gradient. So since carbon dioxide is in higher concentration in tissue versus blood, carbon dioxide will move into the blood. Oxygen will go the opposite direction. Another factor here is that internal respiration depends on the integrity of the capillary. So if you're reading about respiratory pathologies and you see something that affects capillaries, or if a pathology affects capillaries in general, this will lower internal respiration. If blood is sticky, as in diabetes mellitus, where there's more sugar in the blood because of lack of control by insulin, blood won't flow as smoothly through capillaries and internal respiration is going to be reduced. So a common thing in diabetes mellitus is decreased circulations. Also, if capillaries are damaged, as in varicose veins, internal respiration will be affected. Lastly, another common one to think about is when cells sickle, as in sickle cell anemia, those sickled cells can get blocked in capillaries, get stuck in capillaries. That's also going to decrease internal respiration. Next up is cellular respiration, and we're going to keep that pretty simple because in most textbooks, cellular respiration would have been covered when we talked about cells and mitochondria. But it's good to touch on it here because cellular respiration is the ultimate destination of oxygen. It's also where the carbon dioxide is generated. I like to keep this pretty simple, maybe too simple. To make energy, you pull hydrogen ions off of carbon-based molecules like glucose. When you pull those hydrogens off, you put them in the outer chamber of the mitochondria. So you put the hydrogen molecules out here and oxygen will go in here. These hydrogen ions don't like to be concentrated and they try to diffuse into the middle of the mitochondria. In the middle, again, you have this concentrated oxygen. So if these hydrogens can get into the middle of the mitochondria, you're going to get a release of energy, and the hydrogen and oxygen will join to make water. Some of the oxygen will also be attached to carbons. Some of the oxygen will also be attached to the carbons that you pull the hydrogens off of in the first place to make carbon dioxide. So you'll get carbon dioxide. In the end, you breathe in oxygen, you combine it with hydrogen and carbon to make ATP, water, and carbon dioxide. From the law of mass action, then, if you have a lot of carbon dioxide in the tissue, this reaction is not going to go forward as fast, and so you're not going to make as much ATP. You already have a lot of that, so ATP production will be slowed. Anything that affects the mitochondria, so when you're doing your pathologies, just look up mitochondrial disease. It can be really, really interesting. I would just do that as a mastery level thinking too. Just look up mitochondrial diseases. For a long, long time, people thought that mitochondria rarely have anything go wrong with them because if you're not making ATP, you never existed in the first place. But now, mitochondrial disease is tied to things like Lay's disease, even multiple sclerosis, aging, lack of exercise, or the energy you get from exercise increases mitochondrial function. So mitochondria are pretty important. I'm going to jump out here and go through a couple of diseases quick. So we'll look a little bit at COPD and then asthma and then things like tuberculosis. So first of all, COPD is an umbrella term for chronic bronchitis and emphysema. In fact, they're really not even called that often anymore. Essentially, there's damage to the bronchioles. Thus, it's hard to get gas into and out of the lungs, leading to hypoxemia, carbon dioxide retention, and respiratory acidosis. And you're going to see that that's going to have effect on multiple other things when we get to the urinary system. Respiratory acidosis, it'll destroy proteins, it'll affect calcium concentration, it'll affect potassium concentrations. So COPD can create a real cluster mess of issues. Not only are the bronchioles disrupted, but the alveoli also pop into very large alveoli. This makes it difficult for gas exchange to occur. So you'll see this in lab as well. Asthma is characterized by inflammation of the airways. The infiltration of fluid narrows the airways. Often the airways will spasm and smooth muscle will constrict even more. A full treatment of asthma involves decreasing the inflammation with corticosteroids, so shutting down the immune system a little bit, and also inhibiting the smooth muscle to dilate airways. So if there's also fluid infiltrating the alveoli, this is the way I think about it, then asthma can also lead to restrictive problems. So this is not the typical method used to describe asthma, but as someone with asthma, I know there's situations where it feels like not only does it take longer to get air in, so that would be the constriction, but it also feels like I can't get as much air in as if there's fluid in my alveoli that are making it hard for my alveoli to expand. So taking longer to get air in is obstructive. Not being able to get as much air in is restrictive. I'm kind of being anecdotal here and just describing my own condition, but I guess maybe I just have a different form of asthma. Typically, asthma is considered obstructive, but to me at least, it feels a little restrictive. Clearly, I'm not giving exhaustive examples here, but I also want to touch on some other things like tuberculosis can cause a low level but persistent infection, drawing fluid into lungs. When you hear fluid in the lungs, you should think ventilation and external respiration. In fact, when you really get your charts down or you really get the steps in respiration down, you should associate steps in respiration with key terms. like fluid, scar tissue, mucus, that should be ventilation. Fluid, mucus, emphysema, that should be external respiration. Capillaries, that should be internal respiration. Hemoglobin, that should be transport. Mitochondria, that should be cellular respiration. In lung cancer, you should visualize extra cells in the lungs. They're going to take up space where air should be. They also make the alveoli more likely to stick together because cells stick together. About 1/3 of all cancer deaths are lung cancer, and about 90% of those are due to smoking. So it's interesting to see how quickly smoking rates are changing, but almost as interesting as it still exists at all. Sorry, smokers. Man, I used to be a smoker, but it's hard to give it up. But it's one of the leading causes of cancer is smoking and lung cancer. I'll get off my soapbox. Man, I didn't even really smoke real cigarettes either. I smoked wimpy cigarettes when I was a couple years in college. Anyway, so I know how hard it is to quit. Respiratory physiology videos. This is just, again, I might go back to the respiratory physiology videos if you just listen to this lecture, because I think these videos put it all together and we draw it all out, big picture. Last up then is control of respiration. So we'll finish by talking about that. While there's some areas that weigh in on respiration, so some cortical areas that weigh in on respiration, it's primarily controlled in the brainstem, both in the medulla down here and also in the pons up here. So in the medulla, there are two centers, the dorsal or rear one. The dorsal respiratory group appears to set the pace of breathing. So it directly stimulates muscles of inspiration, so like the diaphragm and the intercostal muscles. It's active during inspiration and it kind of shuts down during expiration. So it essentially sends the signal to breathe now and then it relaxes. The ventral respiratory group in front seems to be involved in forced breathing. So when you try to breathe in really deeply, inspiratory reserve or expiratory reserves. The pons, I'm going to go back to this one. The pons is up here, and the pons tends to smoothen out breathing. That's what the pons is thought to do. So just to summarize that, the dorsal respiratory group initiates breathing, the pons smooths it out, and the ventral respiratory group does forced breathing. One other thing to note is that the brainstem is not as protected from alcohol as other areas of the brain, and alcohol is an inhibitor. We often don't think of it that way because alcohol usually leads us to be less inhibited, but it does this by inhibiting your inhibitions. So alcohol is an inhibitory drug. Alcohol also inhibits the activity of the brainstem and can lead to respiratory depression. So alcohol intoxication can lead to slow and even stopped breathing. While the DRG, VRG, and PONS control most of breathing, they do get input from other areas. So emotional centers might cause halted breathing. So when a child cries, they often will cry like, it will affect their breathing when they're crying. Chemoreceptors that sense acid can stimulate the PONS. Irritants in the lung can cause the lungs to stop inhalation. So I think about walking through a lawn that's been sprayed with dandelions, and as soon as I smell that 2,4-D, boy, my breathing halts. So even a stretch of muscles can tell the respiratory centers that exertion is occurring and breathing needs to be increased. Conscious control of breathing is possible, but I think it's interesting only up to a certain point. You can't hold your breath enough to really significantly affect oxygen concentrations or to cause you to lose consciousness at all. All right, so that's control of respiration. There's a whole lot of mastery things. One of the things that you have to do is, again, take a look at this. This is going to be your pathologies that you have to do the test. 25 of the 55 points are respiratory pathologies. All kinds of things. I really like the respiratory system because it just breaks things down. So explain the connection between pain, hyperventilation, constriction of blood vessels, behavioral effects of hypoxia from constriction of blood vessels. What I'm working on here is often in the healthcare setting, you have to treat pain. You have to treat pain well, because if you don't treat pain, it causes stress. It causes hyperventilation. When you get hyperventilation, you get rid of CO2. When you get rid of CO2, blood vessels constrict, and now that's going to be a problem because you're not delivering blood. So there's this whole beautiful connection between, you don't want to have pain because it's going to affect breathing. Breathing is going to affect acid. Acid's going to affect blood vessel. Blood vessels are going to affect blood flow, and that can be a huge problem if you're trying to already deal with somebody that's under stress. Also, maybe look into capnography. So these are little sensors that sense CO2 concentration. It's a growing diagnostic, but it's used by EMTs often. It's used everything like, are you hoarding CO2? Are you getting rid of CO2? Also, it can just be used to simply figure out if a chest tube has been inserted correctly. All right, that's respiratory. Thank you.